Hello, how are you? My name is Ricardo Pintor from Mexico, and I'd like to welcome you to this presentation, which we are going to talk about the current treatments for the management of myopia, what alternatives we have, which are more effective, and how we can use these new tools for the clinical management of our pediatric patients. When we talk about the management of myopia, we need to consider some things first of all, and that is that we all do a refraction issue and to see which one is the main idea to provide a defined vision to patients at any distance, and that is we need to correct the problem optically using the current visual program, and that is what we do when it comes to the management of myopia and control of this. We are thinking of these two things in correcting the vision part at that time, but knowing that we are generating an effect which will slow down and prevent an accelerated growth of that myopia, and with the perseverance of the patient and the follow-up on our part with the appropriate therapy for each case, the results will be fabulous. It is important to know about the level of effectiveness, and that is, how timely and effective is the treatment that I am using according to the age of my patient. Distinct alternatives are used, and some may be more successful than others. However, I need to identify those proportions and know what type of patient I am going to use. They are alternatives of ones that we will then offer and perhaps even use one or the other during the child's development. They are also discussed even at this time, of the possibility not only to think about a treatment or change it after a couple of years, but to use combined therapies, say monotherapy or the combination of two alternatives, which in theory aim to have a more complete result, and that is being worked on, and there are investigations to which we can share. We are also talking about the age of the child, the age of onset, and how it will impact the safety of the treatments used, or in thinking about the future and how effective these were. The curious thing here is the issue of the barriers that exist, and I mean from the perception or the understanding that parents may have of this information. And sometimes it is that it is believed that it will completely cure myopia, and sometimes it is said that it is good because I am going to use this alternative as I am waiting for it to grow there until I was 18 or 21 years old. But since I had surgery and that will be the solution or consider some type of pharmacological treatment for contact lenses, it seems that it is a stage where the child is very young and it would not be appropriate to use it. These are some of the barriers which we are going to find frequently. The curious part is that many of the specialists must recognize that sometimes we also have that mystique or that uncertainty, and we will not necessarily advance with the technologies or the new options. And we ourselves are that barrier to transmit the information to the patients today. The World Council of Optometry has already declared that the management of myopia is no longer a speciality, it is a characteristic of primary management, and that is, it is a standard of care that we must all have and implement as we recognize each of these cases. For a long time, a statistic like this type has been spoken of in a similar way to that of Dr. Brian Holden's study and the projections where the indicated values of myopia in different countries according to the different types of race and as they have been growing. Even the projections, of course, speak that by the year 2050, under this methodology, perhaps about 50% of the world population will be myopic. With the consecutive damages in medium nuclear of tall men who could have that. And it is important to be clear for us that there are those who say, good, well, we have a lot of work to refract, but we cannot have the same inertia and manage myopia as we have been using or doing in the past. Let's talk then about the damaged and the identified that myopia can cause for this type of patients. It is known that if the amount of myopia is proportionally higher, the affections in the different structures of the eye will increase a greater risk factor. And so Here, we already talk about that pathological myopia once it is present. However, we must differentiate from what we believe is a myopia, which psychologically or physiologically is acceptable, or which is there and if it is going to be maintained, then as the diopters increase, we have a higher level of risk. And for example, in a case of recording of at least 1 or 3 diopters, you have in this table, for the case of glaucoma, about 2.3 chances of having a higher developmental factor in the same two possibilities for cataract and 3 times for a detachment in adulthood, and twice more than a person who does not have that myopia when developing myopic maculopathy. If we look at the growth, for example, from about 5 to 7 diopters, as were 3 times, 5 times for the cataract or detachment of the retina, as you can see, it's about 21 times more. So that is a very, very worrying that the myopic maculopathy is up 40 times. And so, what is the level of standard, or what is the level of security that we can have here? We would normally be thinking that maybe we keep below those 3 diopters could be relatively safe or acceptable, and this is somewhat questionable, but it is something in which we can manage or what we can set as a goal for now. What is clear is that we cannot talk about diopters or the axial length of the eye. Evidently, the size of the eye is the one that is going to impact the most, linked to these factors, and it is established that ideally, perhaps below of those 26 millimeters of the size of the pupil, the posterior of the globula would be something convenient or reasonably acceptable to avoid many of those affections in this proportion. And so we have to draw some of these goals. And this is only a reference in relation of where we are and what it is that could happen. Let's then talk about these projections that growth is not only how many myopics are going to see. Obviously, also the number of how many high myopics there are. It is estimated that there will be over 1,000 million with high myopia, and that is myopia above 5 or 6 diopia, and that will have a serious problem with the fundus conditions that we have mentioned, and in addition to the factors and characteristics of the disease. It is therefore interesting that detailed exploration not only takes the refraction in the shadow, but we take a look at the fundus of the patient's eye, who we know are presenting gradual changes according to age and related to the amount of diopters, regardless of the exploration technique that we use directly, and observing a little of the fundus and the dilation with mydriasis or using a fundus camera. And it is important to do this because monitoring and recording, obviously these types of lesions will be presented by the patients. Here then, as you can see, we have some of the conditions, such as the striped background of the myopia, the choroidal conditions such as myopic macular degeneration, through to cataracts and also through to the subject of glaucoma and even retinal detachment. This is a collage just to place those conditions which are shown to my right, which could have been in many of these cases preventable, but because they are linked to the amount of growth in the size of the eye, then this is the factor that we intend to avoid for patients in adulthood. And when we manage their refractive myopia from an early stage and we include the stimulus that the eye receives, it is the way to control that growth that will be gradual as it is developed. There are various alternatives that exist which are shown here, which are defined as behavioral management, and that is about the lifestyle and the conditions where the patient finds. It is known that children who spend more time outdoors in solar lighting conditions, they seem obviously that they have been demonstrated that there is a factor of lower development of slower speed. But especially in children who may be 6 to 8 years old, when we think about a 15 to a 18-year-old young man, and his ocular development is practically over, and his myopia, of course, to help him suggest spending more time with sunlight will not necessarily protect him, or it will not necessarily go backwards. So it is important in stages or in early childhood to suggest perhaps 2 hours per day or perhaps over 10 hours on average per week that they could stable. We will now have a favorable level in which we are already participating in this comprehensive management of myopia. Although it is a mechanism that is not fully known and with certain variables and many areas of opportunity to study, but for now, these seem to be the best recommendations. What we do have are various treatment alternatives, and these have been used probably in the last 10, perhaps up to 15 years, to seek effects of reduction in eye growth, with alternatives and optical designs called multifocal soft contact lenses in orthokeratology. And it can be understood that if we manage to ideally manage, let's say, some proportion which is greater than 50%, then we would be at an adequate level of myopia control. Many treatments that we can use and that do not necessarily reach that 50% because they could be useful at the beginning but should not be the best option to establish it during the entire development of the child. And so it is important to know what we have for our patients is explained, and we will detail and monitor the new designs in each of these areas that have been changing and achieving a more effective level and greater than 50%.
Un comprobado líder en la práctica de lentes especiales y ojo seco. Cuando la precisión importa.
Now then, let's talk about the main elements. One of them is a type of lens with a novelty design, which is the design of a dual focus, and the contact lens that has different discs and rings that alternate in power as it moves away from the central part. It generates a peripheral blur, and so based on this principle, it is that he is working on the design of a double focus contact lens to focus on the my-side contact lens. Now this works through the correction zone, which we talked about at the beginning of this talk, where the refraction power is more or less than 3 or 4, and there would be the recording part that gives the patient the divined vision. But there are other small areas of power in concentric rings that are going to be called treatment areas. And based on the principle of peripheral blurring that it generates, will then generate a stimulus so that the peripheral retina of the patient plays and prevents that growth. Since, these designs, they seek a clear image and have achieved a favorable result in the end. And in fact, I would like to show you here some of the main publications for this type of study. And we have a relationship that then speaks of the refractive change that the patients present and the change in terms of axial length. Now, this study was carried out with the children from a multi-center study and with children who ran simultaneously, the control group, and with the my-side lenses, and with disposable contact lenses and a single-day Clear 1 Pro lens. And we can see how they start in a stage with refraction in a similar problem and when times passes. And the children who used the my-side lens to slow the growth would choose after 6 or 12 months, or 1 to 2 or 3 years, achieving then a level of effectiveness and control, which is over 59% in regard to the refraction. If we also compare the axial length that was presented for this study for 3 years, then we can go identifying, by looking at the time scale, how obvious it maintains the same relationship and the children who use a regular contact lens, because they had an inertia in the growth of their myopia, who used the MySide contact lens and achieved a slower rate already in what refers to the size of the eye, which is and about 52% practically per year in terms of the growth. It is a continuous study, and it is practically on the 6th, almost 7th year. And here we are going to show about the values of 5 years, and the determination was very important after 3 years because it was defined that it was ethically correct, perhaps to involve the children who came with that growth with a design. And it is common to share them with a MySide lens and is also already start in a stage due to older age. And yet, we see the projections at 3, 4, and practically to reach 5 years that proportion. It is maintained for both cases, and the one that was using the regular lenses switched to the MySide lens, now with a 59% correction of the refractive error. And as regards to the axial length, since the same measurements were made, so remember after 3 years that it is a watershed to define in this case, and the same trend could not be continued here as the axial length values were already over 52% effectiveness. And this is a lens that is approved by the FDA and widely developed in the last year and dispersed for several of our countries. And in some cases, we already have it, as is the case of Brazil, Chile, and soon Mexico, Colombia, Costa Rica, and others. So it is important to know about these values. What other alternatives do we have that refers to multifocal soft contact lenses? These contact lenses, designed mainly for the management of presbyopia, have been identified that can generate a success factor for the control of myopia, and in the situation of not having specific designs and the complete science in our countries to address this issue. But perhaps this could be an alternative that has been used for several years, as there are specialists who already have several cases, and there are even publications on this type of design. So we are talking about soft multifocal contact lenses that will be used for presbyopia, and mainly those designs that are in the central part optimized for distance by design too, that is recently also being incorporated into these alternatives created for vision of presbyopia of the control of these that is used for the control of the myopia. What advantages can they have? Like many contact lenses compared to the current one, between rigid and others, because it will have the comfort of the wider field of vision and the possibility of being used in sports, and that is also the aesthetic factor that causes it so that it can be offered to the younger people. If we try to identify any possible disadvantage, it is likely that some patients refer to a lower aligned vision, especially in the initial part of their treatment, when they are using a lens of this type, since they are not used to it, and we are intervening there in certain areas of distortion because they would generate this type of designs. Of course, if you do not have the usual controls, some cases of infections have been reported that we need to avoid in the present to be able to control it. I want to mention or make two comparisons regarding the second design that I spoke of, and the design optimized for distance vision in the central portion. The second design was made recently and has had a recent incorporation also in our countries in Latin America, and this design is a monthly silicone hydrogen lens. I am asked a lot about the bioaffinity alternatives and the Pro-Clear multifocal options. These options, it is important to clarify that they are multifocal contact lenses that are not approved for the control of myopia. They do not have approval They were not designed that way, they are multifocal. However, with some favorable data and some values that show that to have a certain success factor, it also mentions that it is a monthly lens. For bioaffinity, it is a silicon hydrogel, and for ProClear, it tends to have a traditional hydrogel. And so when we can cure or understand that if I do not have an alternative available, several specialists have considered starting therapy with this and to give some sort of follow-up. I would like to mention here that there are some recent studies which have compared this design at the value of more than 250 diopters, and they have shown an effectiveness of about 43%, which is related to the slowdown in terms of the diopters of the spherical equivalent, and around 36% in regards to the axial longitude, and I am referring specifically to the Centro Lejos design, which is created by CooperVision. And this is not a study carried out specifically by CooperVision, but it is a study carried out for more than 3 years, which is called the Blink study. And something important to mention here is that most of the patients who use this lens, a factor to give it a higher quality of vision was to offer or make a refraction which, in the final prescription, impacted and offers a value of about minus 0.5 to minus 0.75 to give a greater quality of vision, not only to move the prescription far away, but to incorporate this lens. And so we want to share this here, but I clearly establish the factors that it has regarding the scope for effectiveness. And also, I must mention that this design is not approved for that purpose, but all the other alternatives that we are making available, we want to speak of clearly. There is an alternative that is used in the United States and that I have begun personally to see with a little diffusion in other parts of Latin America, and this natural view contact lens design is one of the many daily disposable multifocal contact lenses, and also it uses an aspherical design that could fall into the category of extended focal depth. And this design provides a multifocal effect, but only in addition of up to 3 or more diopters. And to select the power, as of course you have to calculate the spherical correction distance and the transfer distance to the vertex, and at a given moment, like the other multifocal designs they considered on refraction, to give the best possible visual acuity to patients. So how does it work, and what are the excellent optics? The company talks about a neurofocus technology, which is basically an aspherical design. That has an extended depth of focus to give a higher quality of vision and to also impact the peripheral area of the retina. And that is where it does the work of slowing down the myopia. And this obviously has its limitations, and there are very few studies that actually support this effectiveness that we speak of this. But this is then based on providing a clear view of the center from a little peripheral blur, giving clarity with a multifocal system, and taking control of the myopia slowdown for this. Most of the studies presented for this design are limited studies, and it is also important to note that currently they do not have FDA approval for this indication. These are the parameters in the lens, which has both a positive and negative values, and this is because they are multifocal lenses, and that is why we have it as the value of 4 to minus 12, because they are multifocal lenses that were originally intended for presbyopia, and in Australia they use it for our approval in the control of myopia, but for the rest of the world it is mainly a multifocal use with the occasional specialist trying to use it for the control of myopia. And so the use of these daily disposable lenses with this EVA material is an important alternative out there to know that is available. Another fascinating alternative is that has spread about recently a lot but is practiced very little in reality is one that refers to ortho K, and this technique is great. It's able and fascinating to mold the cornea, or at least the epithelial area, and generate a visual correction effect. And patient uses rigid contact lenses designed for this purpose. They sleep with them and generate a hydraulic pressure that would gradually shape the cornea, and after a couple of days, they will obtain a defined vision. The results of this on certain patients have turned out to be very, very interesting. It is important here to mention two things. The orthokeratology, which is a technique that exists for many years, over 40 to 50 years, and available designs have progressed, that they have evolved, and I can apply the orthokeratology in an adult patient, and I am giving a visual correction during the day, not while using it. If I use it on a child, it is also a subject of orthokeratology and giving visual correction. However, that is where we see that in children, and according to the game that we can make of the optical zone and level of peripheral blur, considering the optical zone of the lens. The Jubilee size, that is where we are going to find an effect of the control of myopia. But this is very important. Not all the patients that we do ortho K with means that we are doing myopia control, and if we talk about it, we identify each case, then we can monitor and measure these factors. There are different designs and many companies that contribute and provide us with their alternatives, and for this case, but in general terms, these 5 or 6 diopters of myopia could be an option, and that can be used if there is low astigmatism, not when they have elevated values, but novel alternatives that come included with what refers to hypermetropia. In this case, we basically understand the curvature and the power of the myopic patient being able to work in this section. And various studies have, but normally 30 to 63%, the highest values that have been shown and that you have identified. But it is a technique which is very useful, and that it is a very specialized technique which is oriented and very customized for each case. Recently, there is also talk of considering alternatives of the combination of therapy and orthokeratology together, and perhaps incorporating some atropine for vision control. And in this case, as the entire presentation is addressing optimal aspects. The two things that we need to know is that I will mention that we must know that orthokeratology of the first designs simply have flatter lenses, and that they are placed in the adaptation, and that could gradually generate some type of effect, but it is not so controlled and not so predictable. And so the designs have changed, and nowadays there are designs and oblates that can, if it is according to the topographic characteristic to the value of the myopia, to generate a greater impact and predict the exact calculation that is required for the precise focus that we require in central vision, and give an optimal vision. And if we represent it with this graphic here, I would like to show you this. Now let's think about this in the 60s. The flatter contact lenses that increasingly varied the designs and incorporated new alternatives until we reached what we have today with the specialty lenses of orthokeratology, which can favor a mechanical control, and therefore it may impact the vision of the patient. When we see a fluorogram of this type, we generate a change in terms, and we can see that the topography achieve that type of ring, which may have soft contact incorporated, and we are moving it to build on it on the cornea, and so that during the day it is going to have this effect and achieves this vision. Who would be the patient who is going to benefit from this? And what are the advantages? Because in reality, if they have many advantages, the advantage would be because that the field of vision is more before a clear vision during the day, and the lenses never leave the house. And so the lenses always occupies the mom or the father of the children, and it is difficult for them to get lost. And they give very good vision during the day. The possible advantage, because sometimes a certain proportion of microbial keratitis, as some ophthalmologists do not like it that children fall asleep with the lens on and have this concept of fear, and also the same specialists. So we need to take care of them and identify that the risk is not high in general. However, because that comment is present there, perhaps the greatest disadvantage in reality is the scope and range of the prescription that can be considered limited and that do not give a quality of vision as it could be achieved, and the correction of a medium or or medium myopia during the day with a multifocal contact lens. That is to say, in other words, who would be a good candidate? This is a list that we have placed here, and I would think that a myopia would go to 3 or 4 diopters, and it is a very good candidate that the corneal toricity is not very high, and that the astigmatism is obviously regular, to understand that there is not a high irregularity out there that symmetrically does not allow me to work with most designs, and that there is a progression of myopia because parents will be interested and there will be more, and they will be able to demonstrate the effect more. Of course, due to genetic factors, here we also need to have those present to know how it is developing. But the main principle, if we have these parents who are detailed, who follow their children, who look for who they are going to be present and who are going to accompany them, they are going to be a very good candidate because they understood the technique. But who could be the bad candidate? It will be the person who has a myopia greater than 7 or 8 diopters, because we are hardly going to have all the scope that we want. And so we will have to monitor and look at what designs already exists and what alternatives, according to the manufacturers, can we count. But for these values, it is difficult to be able to handle the same astigmatism of more than 2 to 3 or 4 diopters. And it will not be easy to incorporate it because we will not be able to achieve the greatest correction. And it will impact on the centering and in the control. It is important to note that when the corneal astigmatism is from limbus to limbus, it can generate a certain leakage in the lens, and it does not achieve the design that we are looking for. And so it is usually when we have cases of central astigmatism that we see in the topography, it normally has a better impact. Those patients who are very picky and that they are looking for quality of high vision, especially in the initial part, or that there are fluctuations during the day, here the size of the pupil is very important. A wide pupil is not going to favor us. For example, if we want to talk about myopia control, but if it is a small pupil, we are not necessarily going to achieve that impact with wide pupils. And sometimes we will present some kind of flare, and those patients who are going to be complaining habitually of glare from areas such as blur,
Tienes una cita presencial con tu preparación académica, con los profesionales de la salud visual de América Latina, con los negocios.
Asegura tu cupo en franjafedopto2021.com inscripciones.
Enfrentando eficazmente la era digital.
because they are not necessarily going to have the highest quality of vision. We now continue with very interesting ophthalmic lens alternatives, and they have had a great advance in recent years. We can talk about the strong bifocal base lenses or progressive lenses that are used for the correction of visual problems that have also been used for the control of myopia. In this case, it is not a design that is specifically created for the use of peripheral blurring that it can cause, but mainly it also addresses the aspects of binocular vision, aspects of accommodation, and the vision corridor. And it is the one that can give us some effect on it. And some designs have been named specifically for this purpose today, and it is used a little less, and they did not have the expected success. And I believe that cases such as myopilux or myokids, these designs work in manipulation of accommodation and convergence to have an impact on this. And we need to understand then the different areas of vision, the aesthetics provided by the lens, and the intended use for these initial alternatives for us to search for a myopia correction. The progressive focal contact lenses and the variants that have been made, such as incorporating, for example, a base prism in these executive lenses in these bifocal lenses, have certain factors and have been studied asking things like, which is the correct addition, or how could I achieve it? This value on the graph, indicated by the orange bar, shows us the result, for example, of the reduction and the control of the myopia at 39% with 1.5 diopters, with an increase by just incorporating a base prism inside. And this means that the fact that these binocular factors also have an impact on the relative reduction of myopia control, which is used on children. It is possible that this small reduction in the progression of myopia is linked to the areas of blurring that the lens will generate when in use and causes myopic blurring on the upper retina, but not on the entirety of the eye. And in reality, it is not clear where the areas where we need to address these designs would be. Now, they are very good. It is a very good approach, but not the best alternative to talk about controlling myopia in children. What actually is a new system, however, are these new generations of designs, like blurring in the links and in the hub, which we are going to mention, and are truly new technologies which are incorporated in ophthalmic lenses in search of slowing down myopia growth. Now we have here some options that we are going to describe, and we need to think of it as a lens that will give central visions, and it will generate peripheral effects that can contribute to the quality of vision of the patient, but that will also mainly be controlling the myopia. We see in this case, this photograph is fabulous. It shows us there in the projection of light that is made in the lens, and it shows us how it is constructed and how it consists of a way that on the entity we do not see the change, but in the projection that we have. And so, these are the DIMS technology, and the concept is a simultaneous blurring that is causing this vision. And it can be understood that they have powers of 350, and as if they had micro additions on the periphery of the lens. And this is how they are going to work. There are different houses, both the commercial housing Hoya lens, it has the Mayos Mate lenses, and the Carl Zeiss lenses. And they have this type of lenses that not necessarily are available in Latin America. But what is important to understand is the technology that we have and how companies are gradually trying to take them to the countries. They are designs that are expensive, and it is important to know that sometimes we see this and we believe that it is something fabulous, but we can understand that they are a design with a higher cost out of any of the alternatives, which control the myopia, and each case will have its own reason for being. If we look at the simultaneous blurring that these lenses generate, we can understand that in the blue section, where I would carry the correction of the water of that visual and the refractive error, and in the peripheral part of the lens, where these micro bubbles are, the positive powers, they will generate and blur in the central part and a clear vision. But in the peripheral part, it is the blur that is going to be causing a stimulus to avoid this growth of the size of the eye. These multiple segments shown in photographs that show us how we can see it against the light or with a specific type of lighting. The patient in general does not suffer from it, and these are the ones developed in-house for Hoya lens as MyoSmart, that was developed by the Polytechnic University in Hong Kong, and is commercialized, and the license is distributed around. And so we can see we have a centric optic of 9 at 10 millimeters, and in the periphery is where they found these power zones with a range of more than 350 diopters. We have a video that we are going to show you about, and it is so that we can see the effect that it achieves. And what is important to understand then is that the children who use this type of lens are then achieving 50% of the area for a clear image on the retina, and 50% of the rest of the lens generates a peripheral blur, and the results in the studies show a control of around 50% of the myopia. And with regard to the control of the axial length, and that is up to 60%, this seems to be something interesting that is in the part without molding the cornea aligned with the visual stimuli. Here we can see the design, which we are going to talk about. And how it is seen, and this is seen under a slit lamp, and there those spare parts are tracing the central area of 9 millimeters, and the type of lighting allows us to see these small caps as if it was a golf ball, and those are the micro lenses that will generate the peripheral blur to control the myopia. The video is incredible to look at, and the blurring area where these micro lenses are, which are carved onto the anterior surface of the lens. It is not a film, it is not a layer that adheres, and this is according to the prescription that the specialist can highlight to the children. This shows the balance of the lens, which is very important to show in this moment. There is another type of lens that exists, which are the highly aspherical technology that they are going to have and are recently developed by the Essilor company. And this excellent lens is a different type of lens from the defense technology to Esteban de Marjal, and what it provides is a volume, and it says of the blur in the peak of the myopia, and that is, considering all the light in the scheme, we already see three-dimensional, and it will generate a volume of the refraction in the peripheral retina that will generate the necessary stimulus to prevent the growth. And so we pass in the aspherical lens that the three-dimensional volume of the blur in front of the retina for the patient. If we view the dimensions related to the scheme presented to the company, we can begin to understand how the central part with the same form achieves a sharp central vision, but the rest of the spectrum will generate an image that will be put before it, and that will pass to the side of the retina and the whole of the ocular structure. And this is the thing we assume will give a stimulant ocular growth. Here, the results of a recent technology speak of an average deceleration of 60%, which refers to the refraction. However, in what is the axial length, and the study we have shown is at least present, and the axial length of 28% in the children will avoid these growth, and it is to say that there is a favorable and promising control for these types of technologies. If we look at this shape, which is similar to the DIMS, we see a transparent lens, which shows the results in the peripheral, and is a type of lens constellation that will remain fixed. As we can see, they are diverse alternatives that the industry will continue to provide, and new investigations offer to have something effective. But all of these will be something that a specialist will determine, which they will give to the patient depending on the patient's country. There are three important factors to consider. The first, we must take measurements for the control of the myopia. and I must have the exact refraction in which I must understand the size, which implies how much impact a biometric will have on ocular health for the patient. And so I must have the measurements where I will start to avoid this pain, which we are talking about. One of these is to have the axial length as far as possible. This is a critical factor and is one of the most desired factors, as not all specialists can have a biometric to size up the directional light for each patient. But once you enter this matter, we can request the study as a reference as a base of control, which will be very appreciated, and that the specialists will have this value in their description. And the main important thing here is the clinical route of management. If I identify to the myopic patient and get to know what I am going to act on or how I am going to get there, along with the treatment plan I am going to implement, there are different alternatives, but the most important thing is being able to do something, as it is more valuable to start something rather than letting a case pass by or something changing in these types of patients. Well, I thank you very much for your time and allowing me to present. It was a quick recap on the different alternatives, but with commentary from my point of view. And I hope to be able to help and support you all with new technologies and new presentations that are specific to each of these cases. And I hope that this presentation allows those with an interest with myopia control to better their knowledge and expand their knowledge. Thank you very much, and until next time.